Okay, guys. This is myofascial trigger point injection. It's a very simple lecture, very quick lecture. And at the end of the lecture, what's up, Hector?
No, just the best
At the end of the lecture, if you want, we can do one quick short exam of showing you how to do a shoulder exam. You know, because it's pretty quick. Okay. So myofascial pain, as you know, is basically muscular pain issues. It's spasms. It's reproducible. The key is that it's reproducible. It occurs a lot more in females, and it can be anywhere in the body. Okay. And it's basically, do not confuse myofascial pain syndrome, even though they overlap with fibromyalgia. Okay. When there is a myofascial pain syndrome, and it's classified as myositis and myalgias, it has the same code and as fibromyalgia. It could, but the thing is, they're not the same type of patients, even though some of the things do overlap. They're easier to treat. So basically, trigger point is a hyper-irritable spot in the skeletal muscle that is associated with palpable nodules, what we call taunt bands. Prior to the changes that the insurances have made, the diagnosis was, in order to do a trigger point injection, was that you had to call it a taunt band. But now things have changed, so it's not the same thing that you can use. It's the basic thing with the taunt band, and what the difference in a real true trigger. We do a lot of trigger point injections, but a true trigger is that when you press on it, you'll feel it. It will reproduce a radicular type of radiation therapy, and you'll feel the snapping of it. Okay, you'll feel it under your fingers. Now, the best way to feel it is that you take a little bit of an alcohol, you wipe the area, and it's slightly wet, and you pass your finger through it, and you'll feel the thing. When you press on it, you will have a reproducible pain that will spread. That's a true trigger. We see a lot of trigger muscle spasms, and we call them triggers. But the true trigger is really a tight band, a nodule that you will feel that's palpable, and it will cause a referable pain, almost like if it's like a radiculopathy. So if you have a pain that's on the superior part of the trap, you press on it, and a pain shoots down the arm, that's a true trigger point in palpable nodule. And that's a true trigger that you can really inject. It will give you like a radicular kind of symptoms. There is a short active trigger point, and there's a latent trigger point. What a latent trigger point is, it does not produce an immediate pain. It develops a nodule intermuscular. It is in a more deeper muscle area. What it causes is decrease in range. It will inhibit the range of movement, or the range of the area, and that's another type of a trigger point, but it's more deep in the muscle layers. Okay. So the pathophysiology, as we know, it could be nociceptive, central sensitization. They have the whole gambit with the points of neural hyperactivity, dense collection of nociceptors, and they can have a whole cascade of triggers that end up causing that little contraction of the muscle to lead to a nodule formation, and the irritation can be found anywhere in the body. You can have tender points in any of the body. So that's why it's trigger point in points with myofascial syndrome is very much confused with also fibromyalgia. So basically, you have a trauma, you have an inflammation, you have a damage, you end up with sensitization of the alpha, delta, and the C fibers, which will then lead to a persistence of an impulse that will slow the onset to a persistent, ill-defined ache. It's a big cascade that leads to a constant pain with the trigger. The importance of knowing the alpha, delta, and the C impulse, and knowing the spinal reticulum pathway to the limbic and to the frontal lobe, etc., is for your board exam. Okay? Those are board questions right there. You're never going to really need to know about any of that, but you have to know the alpha is the sharp first pain, then the C impulse is the one that travels the spinal reticular pathway. These are board questions that come up. So what happens, it's basically the damage occurs in the sacroplasmic reticulum and the release of calcium ions, and the formation of the contraction occurs. Then this contraction, what's important, is sustained. So if the contraction sustains, how I explain it to the patients, that the muscle irritation causes a muscle contraction, and then the muscle forgets to relax. It just maintains it. And that becomes more and more and build up and into the sensitivity of what we feel as a nodule taut band. So, several factors that predispose some people to having more trigger points than other people. Could be many etiologies. It could be from anemias, it could be from vitamin deficiency, leg length discrepancies, it could be from abnormal stresses, it could be from the way that they carry their bags on one shoulder versus spreading it out equally. It could be multiple reasons. It could be from even hypothyroidism can predispose people into having more trigger point points throughout their body than other people. Poor posture. It's mechanics. In rehab, we talk about mechanics. What they say in rehab is that the least painful and the posture that you could maintain is an erect, straight posture where there is no deformity. As soon as you deviate from a normal erect posture where there is least amount of pain, you start to develop pain symptoms. Rounded shoulders, leaning forward. What happens? Everything in the body has to compensate for it. So poor posture and poor stance can cause you to have more muscle spasms, more contractions, and to have more pain in overall general, whether it's taut bands or whether it's general. Leg length discrepancy. How does that happen? Now I have a high heel, and then now I'm going to walk like this. Okay? If I walk like this, what does the muscles have to do? They have to compensate for the difference. So by compensating for the difference, how do they do that? It's either by contraction. And that contraction causes in certain areas, some people are more predisposed than others, and starts to form nodules throughout the body. It's just general, I always tell patients, it's mechanics. You throw one thing off, it's mechanics. Something else has to compensate. So basically, we went through all of this. What's important is that there is no atrophy. There is no notable muscle weakness. That's the key in a trigger point. You're not looking for a neurological deficit. There is no neurological deficit, no atrophy, no notable muscle weakness. That's the biggest key in this thing, so that it can rule out something like a root compression, something severe that needs an immediate medical or surgical assessment. Basically, the diagnosis, as we've went through, the taut band is a microscopic contraction, knots at the end plate zone, which results in excessive release of acetylcholine at the abnormal end plates. You can do it as confirmatory observation with visual, tactile, or you can do with the pain that can be reduced. What's important is that they found that in the skin, resistance to electrical current has been slightly lowered with the active trigger points that are found there by spontaneous EMG studies. This is important, so they have been able to reproduce and diagnose trigger points or taut bands with EMG studies. Now, are you going to do that to every patient? No. But they have done the studies, and they can find that there is true trigger point and the reason for the EMG changes. The only thing that you need to take out of from this for your boards is know that spontaneous EMGs with trigger point show spike positives and low amplitude. That's the only 2-3 words that you need to know. That's for the, and on the pain boards they do ask about EMGs.
If it's not a trigger point, what would it show? Would it show
Silent.
high amplitude?
No, nothing. That's just the EMGs, then there's just as a change. EMG findings, you can have positive sharp waves, you can have negative or the reverse amplitudes when there's an abnormality. The thing with the EMGs, they always try to figure out whether it's radiculopathy versus neuropathy versus myopathy versus whether it's a trigger point. Those are the changes you have to look. So the amplitude is important because that will differentiate from radiculopathy. If it's normal, no changes, it's not going to be anything. You're not going to find any of those findings. The treatments. Non-pharmacological, so postural changes, you send them to physical therapy, you do massage, TENS, acupuncture, you can do even electrotherapy, stims, all of this stuff, magnetic therapy. And then you have your spray and stretch, you can do thermotherapy, strengthening of the muscles, improving your mechanics. Then you can even try pharmacological, the NSAIDs, the muscle relaxants, all depending on what the the cause for these trigger points is really what the treatments you would choose. But the best one is what I like the best is the trigger point injections. Now the difference between dry needling, injecting with steroids, without steroids, just locals, and Botox is a whole nother story. But in the trigger point injections, they have done studies where they found that there was no difference between dry needling or injecting with local. The only difference is between dry needling and local is that after the injection there is a severe amount of irritation and pain caused on the patient. If you do it with a local, you'd reduce that. It's for the comfort of the patient, but there is technically, in many studies, which I have it toward the end, there is no difference between dry needling or injecting with medications through a true trigger. So how do you do it? As I said, with this alcohol swab, you wipe the area so it's moist. Then you go through with your finger and you feel the knot. Once you feel the knot, you go one finger, next finger, you'll squeeze right there, and that's when you put in the needle. Not a direct 90-degree angle, but a slight angle. And you go in, and you go out. You have to be careful depending on what area you're on. If you're up here in the upper traps, in this area, you have to make sure you're not using a 2-inch size needle. This patient is thin, and you're going down and hitting the apex and causing pneumothorax. Or you're right here, a thin person, and then you're going in right through the intercostals, and again, causing pneumothorax. What's important is that you feel the skin, okay? You feel the skin, and you make a little pinch. That little pinch, and then you go through. As you're going through, a true trigger will give you a feeling of a sandy, grindy sensation. That's when you know you're really going through a true trigger. A smooth in and out is a smooth in and out. And if that's what you get, just give a little bit of local, and that's about it. So, as we went through this, they've done many things with local, etc. And in Europe, some people inject, instead of the local, they inject with Voltaren. Some like Toradol, in Europe. A little bit of steroid. I'm not in favor of doing steroids in the trigger point injection at all. If I do it, I just do it with plain local. But I can see the logic of using a Toradol or any kind of an anti-inflammatory. That might make logic. I haven't used it, but in Europe they do use it a lot. Again, we went through all of that. It's the dry needling, and then the pathophysiology of how dry needling versus if with without the impulses. I'm not going to go through that. The study that implicates that the efficacy between dry needling versus with medication, that it really doesn't make a difference. This is another study showing the same concept. More studies. Basically, we're done.